on this episode of A Tale of Two Hygienists.
I remember having conversations with my patients, my first patients in hygiene school, and my big emergency message to them was like, you're going to lose your teeth, and what we've learned from it, it's not just tooth loss. We know that this destructive bacteria can travel through the bloodstream to other parts of the body. It's a lot more serious of a conversation.
I almost wish we would have called it biofilm DT, because I do think hygienists think that it's only for patients with periodontal disease, but this is truly a biofilm management product. It has such a wide scope for your patients, even your traditional prophy patients with a little bit of calculus and biofilm or a localized area of inflammation. You can use this on.
The mode of action of the desiccation technology is that it is a sulfonated phenolic. Those are the ingredients, sulfonated phenolic. And it's going to actually be attracted to water, so it's going to pull the water from that biofilm, from the bacteria.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome in, everyone, to a special episode of A Tale of Two Hygienists podcast brought to you in partnership with Young Innovations. And this is an important episode, everyone. Thank you for joining us this weekend. One that I've actually been trying to get done for months now, because this topic is incredibly important, not just on social media, but really in the hygiene community. It's just there's so much buzz around it. And so today we're going to be talking about PerioDT. And in this age where we have all of the knowledge of mouth-body connection, the inner workings of how disease and inflammation work, it's still a bit mind-boggling that many of our colleagues' day-to-day involves just scaling and polishing, and no real disruptor adjuncts being used. Well, in this episode, we talk about all of the applications of PerioDT, how it works, how to use it, and we even touch a little bit on the billing and the cost aspects of it. A 30-minute episode, while it was phenomenal and great, it's going to give you a lot of the foundation that you need. It just isn't able to do it all of the justice that it deserves. So please use the links in the show notes. Follow them on social media. If you're attending RDH Under One Roof, they mentioned that they'll be there as well. And you got to check out their webinars and other learning tools and get this product into your office. It's truly a win for you, definitely a win for the patient, and even a win for the practice. Special thanks to our guests today, Peggy, Monica, and Lindsey. And with that, let's get into the episode.
A tale of two hygienists.
Welcome into the interview portion of the podcast. Thanks for joining us today. Joined today by Peggy, Monica, and Lindsey. Thank you for being here.
Thanks for having us.
Yeah, thank you.
We're so excited.
So first of all, first podcast that you guys have done? Second, third?
I did one for a DSO actually, and it was just within their organization. But so my second.
Nice.
Well,
I think this might be my first.
Yeah.
So yeah,
Excellent.
I'm excited.
So here's the thing. This is just imagine the listeners. We're all dental hygienists. We're all a bunch of buddies. And I just want this conversation to be just like we would have at the conferences, right? We're sitting, after the courses. We're just talking about some really cool stuff. You all work kind of in the DSO space. Is that correct?
Yeah.
Yes. Mm-hmm.
What exactly is your role, and what is kind of some of your background?
So we're all hygienists, and we all have varying experience in the hygiene profession, and at different ages and experience as far as the years we've been practicing. But we work as clinical implementation managers. So we implement our products within the clinical space. We work with various DSOs, different size organizations, from the really large ones to our small regional DSOs. So we do education for them and help to implement products into the clinical side.
Yeah, and the three of us cover the country. So it's really exciting. We kind of split the DSOs kind of per region and get to just go in and help from a leadership standpoint, help to implement, like Peggy was saying, new products, product training, but also almost like a consulting role because we get to give advice. We collect so much information from being able to touch point with hygienists around the country. So I love being able to take what I learn and share best practices with others. So I like that we get to see so much and we're not just siloed in one area.
What do you feel like are some of the kind of the pain points that hygienists are experiencing nowadays? Because I feel like it kind of evolves every couple of years. There's always a new pain point.
You know what? Right now, I am hearing that they just feel overwhelmed. There's a
Yeah.
lot of new technology out there, and I think it's just feels like a lot to implement in one appointment. And so we try to help them break that down.
I think the other thing that we hear all the time is budget, right? You'll hear that in private practice or at DSOs, but one of their biggest pain points is not being able to get the equipment that they need to do their job efficiently. So we can only do so much, right? We take the advice that we're given and we try to share that because we're in a unique situation in the sense that we are boots on the ground where we work with the hygienists, but we also have meetings with procurement and their hygiene executive leadership team. So we hear it from both sides. So we're almost like a middleman. We're trying to be their best friend and like, hey, you can do this, it's coming. I've heard that they're going to get you your instruments you need, and so we get to know them on a personal level in so many ways too, which I absolutely love.
I love that. I mean, because there's nothing worse. And I mean, I don't know if you all, had DSO background before or private practice or maybe both, but like there's nothing worse, in my opinion, than the lack of communication that comes down to us. Just like waiting and waiting and waiting for like the instruments per se. Like just waiting for this thing that we were told that we're going to get it, but then there's been no communication whatsoever. So
Mhm.
having someone that can kind of like back channel a little bit and like advocate for the hygienist on the one side, but then also help, be with that communication, um, you know, arm or outreach arm for that is awesome.
That is spot on.
Yes,
Did
it
all
is.
of you work in DSOs before?
I
I
did.
have never. Yeah, I came from private practice, and so it's been an eye-opening experience, but also something I've learned is that no two organizations are the same either.
No.
And, some do formulary, some have autonomy. There's just so many varying levels of, support when it comes to that end of things. And so that's been an eye-opening experience too. But like Monica said, we really do try to translate things that we learn that work well into other DSOs to just kind of help. And we do a lot of consulting. Like I get emails from different regional hygiene directors. We have an office that's really struggling with their perio program. Do you have things that can help? And we do have courses that we outline, staging and grading and that kind of stuff. So we start with the basics and then we kind of build, towards what their initiatives are and what they're looking for too. But it is so important, especially like when it boils down to like instruments and, obviously that obstacle being budget. So it's different and it's interesting because all of our clinical experience is what gives us the background knowledge to have these conversations with everybody. So we all have varying degrees of that experience. So we bounce things off each other all the time. I just texted them this week and I was like, hey guys, has this ever happened to you? Has anyone ever mentioned this? And they all are like, yes or no. Like we all kind of rely on each other too.
Yeah, this is a dream team here. We say it internally,
Oh,
we
I'm
say it
so bummed for these.
externally. Being able to work with Peggy and Lindsey has been just like eye-opening. It's been comforting. It's been a lot of things because we can actually do our role, learn from each other, but also just like support each other, I guess. And one of the really great things also that we do is we help to build out like regional events. Like, let's say there's somebody who's new in a hygiene leadership role, right? Because hygiene is really great now with DSOs. There's leadership positions you can take. You can be a regional coach, you can be a hygiene director. And sometimes they're new to the role and they don't necessarily have their footing yet. So that's where we come in and we can say, hey, you know what? Let me help you. Let me give you some like tips and pointers of what we learned from working with some of the greatest in the industry. So we will help people to, kind of get things started in their own right and help support their regions with the implementation process and with that communication, hopefully, because that's the piece that, like you said, is missing a lot.
Yeah, I think I mean, what first of all, going back to what Peggy said, I like that you said that, all the DSOs are just a little bit different because I think for the listener, they hear DSO, they hear organized dentistry, they hear corporate chains, whatever they have like a notion in their head, right? That they can't
Mhm.
shake it. And it couldn't be further from the truth. Just because there's a quote unquote DSO is not going to be the same as, Aspen and Mortensen and Heartland and, you know,
Yeah.
Sage Dental, all different ones are all
Mhm.
so different. I was going to ask also though, it feels like there's a bunch of emerging DSO. Like we call them emerging markets. I'm not sure if that's the same term that you all use, but it's the teeny tiny DSOs. Are you seeing a lot more of those cropping up? And are those the types of leaders that you guys are helping?
We do see them often, unfortunately, because we are a small team, sales force, if you will. We really are only working with the larger organizations. Not to say that we can't go help them if they want a product implemented or a launch, we absolutely will. But when it comes for the three of us in our clinical implementation position, we are supporting more of the larger organizations. Now, our two sales reps are covering everything. They're working with
Sure.
all of them in the sizes, but as far as support, we typically are with the larger ones.
Yeah. I'd say we each have about 15 to 20 DSOs that we're actively
Mhm.
working with. And then we can get pulled in with other emerging or mid-level DSOs
Yeah.
as the opportunities come.
Mhm.
Yeah,
Yeah.
for sure.
That just makes sense. One thing I want to talk about is because, we're going to jump into some product discussion a little bit. I think it's important. So I have a role at a DSO, and one of the things that I'm always looking for is something that's going to, one, make my hygienist excited and happy to be there.
Yeah.
Two, that's going to work for them. And three, that's going to save them time and effort. So there's so many things, but I want to talk about just like the overall shift to like this biofilm management concept.
Oh, yeah.
You had mentioned, I can't remember if this was actually on there. So you said 17 years ago when we graduated. Um, was this, so
Long time ago.
I graduated on the same time, right? And it's just like, I feel like biofilm management wasn't really talked about as much. I know the clinical boards don't really look for, they don't make you disclose these mannequins and see if you're disrupting the biofilm. Um,
Right.
what have you all seen in kind of like that arena and that shift in mentality?
Well, what we know is that it's a conversation that we have with our patients about it's not just tooth loss anymore. To start very basically into the conversation, I remember having conversations with my patients, my first patients in hygiene school, and my big emergency message to them was like, you're going to lose your teeth, and what we've learned from it, it's not just tooth loss. We know that this destructive bacteria can travel through the bloodstream to other parts of the body. It's a lot more serious of a conversation, and not to be like a Debbie Downer on the topic today, but it's a lot more serious. We know about things like head and neck cancer and pancreatic and kidney cancer. So it's a lot more serious of a conversation. And if we can help our patients really understand that they're not just going to lose their teeth, there's just so many systemic things that are going on. So it is so important to get some good biofilm control in there to really help, eliminate the bacteria and stop it from replicating because that's really our primary etiology when it comes to periodontitis anyway.
Yeah, I think that we, as hygienists, as clinicians, we know that biofilm is a complex matrix of bacteria. So I think the knowledge is there, but when it comes to the treatment, we haven't necessarily pulled it through to how we explain that to a patient or understand maybe the why behind why we're pulling in adjuncts, right? We're using our instruments, we're using our power scalers, we're using lasers, and now it's just something to talk about, this dysbiotic biofilm. So that's how we like to position it, or that's what we hear about dysbiotic biofilm. There's more bad guys than there are good guys, and it's not all, we can't see it all. So we love partnering with hygienists who use an endoscope and who use lasers because we learn a lot from them too.
Mhm.
It's interesting, Peggy, that you talked about it's not about missing your teeth because how many times do you hear like, well, grandpa lost his teeth at, 45 and they're just, it's so normal to them. But then also, by the way, grandpa died of a heart attack at 55. And
Yeah.
it's like, oh, maybe there's a different correlation that we need to be focusing on,
They'll just
not about
say,
this.
"Oh, it's in genetics. I've got bad teeth.
Yeah. I have soft
Get with
teeth.
that
That's
line."
what they always say. My
Oh,
teeth are
the
just
soft
soft.
teeth.
Yeah.
Yeah,
Oh,
yeah.
that too.
Like,
Oh, yeah.
oh, yeah.
Drives me
Nope.
crazy.
That's called periodontal disease.
Yeah.
So helping our patients just try and find the link in all of this is, I think, just super important. And we could probably have a whole nother podcast about patient education and things like that. I want to stick more with like the clinical hygienist. We're going to talk about PerioDT today. Tell me more about like, because when we first had our kickoff call, and then even before that, I just think of desiccation technology. Like that's all I hear about. But I'm finding that I'm a little bit wrong. Because I think that's also what the hygienists are thinking about. So help educate me a little bit on this product.
Well, it's desiccation technology. I mean, that's what our DT stands for, right? PerioDT. But in the name of it, I almost wish we would have called it biofilm DT, because I do think hygienists think that it's only for patients with periodontal disease. But this is truly a biofilm management product. It has such a wide scope for your patients, even your traditional prophy patients with a little bit of calculus and biofilm or a localized area of inflammation, you can use this on. Your 43-46 gingivitis patients, this is a game changer for them, right? What about
Yeah.
localizing your perio maintenance? So you got to think outside the box and not just a true SRP, because it has so many benefits for biofilm management, because it really is desiccating, decontaminating, and detaching all of that necrotic tissue, the calculus, the biofilm from that pocket. And it will give you those immediate effects, but also long term antimicrobial effects for up to a year, which I think those studies and the slides that we share are game changing. I love to watch hygienists' eyes like open when we show those slides because we've got them on the microscopic level. We can show you the gram negative and the gram positive bacteria literally lift and shrink up off the tooth. So that's a added benefit that
Yeah.
hygienists are like, "Oh, I just want to scoop that off. It's going to be so much easier." So not
Yeah.
only is this product going to help you be more efficient as a hygienist, but it's selfishly but excitingly also going to make your job easier. So
I always explain like so it dehydrates the biofilm, right?
yes,
So and what
absolutely.
it actually does to the hard deposit is the same. But the I always use the analogy like if you were to slice an apple and try to break that apple slice in half, because of all the water and stuff, you would probably be able to eventually snap it in half, but it would take you some time. But if you dehydrated an apple slice, you'd be able to snap that thing into a million halves, right? And the same thing happens to the calculus. It gets all the water gets pulled from it and it makes it brittle. You can see in the slides that Lindsay was talking about. We like nerd out over these slides that we have in our deck. I swear, I'm always like, oh, here's one of the slides. I love to show the one where it shows you like it kind of pulls the calculus away from the tooth structure,
Yeah,
and you
like
can
a
get in there and
flakiness,
scale
like
it
it's
off.
flaking off the
Yeah,
tooth, yeah.
it makes it more brittle, and so you get that like snap. You can imagine just a dehydrated apple slice. Just you can snap it in half, and the same thing happens with the calculus. It's just easier to scale off. You get that biofilm control too. And then another thing that it can help with is heme control. So it helps to coagulate
Mhm.
and you get a better field of vision. It's frustrating when you have a patient that's a bleeder. There's a lot of different reasons for it that happen. But when you have a product like PerioDT, you can use a little bit more of it and get that heme control. So you got a better field of vision. You're not, well, we're scaling blind most of the time anyway, but you're not scaling really blind with all the bleeding added to it, right? And then you can like release your patient and not feel bad that they're going to bleed the rest of the day.
Yeah, I think, desiccation is an adjunct, but like Lindsay said, it can be used in a wide variety of appointment types. So when we think about adjuncts, I think hygienists a lot mostly think of localized antibiotics as one of the big ones. There are other adjuncts out there, but the function of antibiotics, the mode of action here, and I'm getting to something because it's the mode of action of PerioDT, the mode of action of this desiccation. So when we think about localized antibiotics, the mode of action primarily is to suppress replication of bacteria. But what the desiccation technology is doing, it's actually eradicating that bacteria on contact So all the work is being done that day in the appointment. It's nothing that you leave behind in the pockets. It's nothing systemic. So we find that that's a big benefit because we can be in control of that and the patient will see those benefits. The mode of action of the desiccation technology is that it is a sulfonated phenolic. Those are the ingredients, sulfonated phenolic. And it's going to actually be attracted to water. So it's going to pull the water from that biofilm, from the bacteria.
And
So
it's not able to survive. Kills it.
a couple of thoughts about this. One, I can already tell you're very nerdy, all three of you, about this. Two, the way that and I wish that we did a video podcast sometimes, because the way you light up about how you describe like the watching of this reminds me of those videos where people have like, their ultrasonic scale and there's like these big old chunks of calculus coming
Oh,
off. And
I
like
love
so
watching those. It's
gratifying.
very sad. Yeah.
Yes.
It's like
So
a
if
hygiene
someone,
version of
Very
ASMR,
satisfying.
right?
yeah. And so I was just thinking, like, someone had a
Come on,
TikTok
Lindsey.
account that had nothing but like just this action going over and over, like the new videos every day. That would be so great.
It
It'd be
would.
like
Yeah.
watching those pressure washer like videos like that.
Ooh,
It just
Yes.
so
Very
satisfying.
satisfying.
yeah.
So we have a lot to cover. I talked too much in the beginning, so I'm gonna like kind of rapid fire some questions at you all, so we can get through this because there's so much information here. And listeners, if I didn't get to one of the things that you wanted to ask them, make sure you reach out to them. Teaser, we're gonna talk about this at the end, but they will be at RDH Under One Roof. So if you are gonna be there and you have questions for them, make sure you ask them in person because I don't know if I'll get to all of them. But I want to talk about okay, so patient selection we kind of already covered. It's kind of good for all these different scenarios, whether it's isolated, localized, or whether it's generalized. I want to talk about just like what does it look like and the actual application process. It comes in a syringe, right?
Yes.
How much do you use? Where exactly do you apply it? And all of those things.
So we actually have two different size syringe. We have a 1 milliliter and a half milliliter. 1 milliliter is great for 2 quadrants. So you do actually have to apply this twice in the appointment. You're going to do it first before you do anything, then you're going to scale, and then you're going to finish and do it again at the second time. So that one syringe is great for both applications for 2 quadrants. And if you needed a localized area, that's why we have smaller syringes. So if you needed to just put it on the linguals of the lower anteriors, or if you've got a couple pockets with your perio maintenance patients, the smaller syringe is great for localized. But you're going to place it subgingivally into the pocket at the base of that pocket. It comes in a gel or a liquid form, and that's totally clinician preference. It's completely up to you. The formula is exactly the same. So we can touch on why maybe you would use one or versus the other, but you'll put it subgingivally, you'll bring it to until you see it at the gingival margin, and you'll just apply a couple teeth at a time. This is a very fast acting product. So 10 to 30 seconds is all you need to leave it on. Then you'll give it a good rinse and suction, and then you can continue applying it to a couple more teeth. I know the three of us always recommend just to do sextants at a time, one surface at a time. So just start on the buccal, then rinse it off, continue on, because you don't want to leave it on too long. Not that there would be any damage to the tissue or hurt the patient, because this is a dehydration product, right? It's not an acid etch. We are not burning the patient's teeth. We tell our hygienists that all the time. But you can over dehydrate if you leave it on too long. It would just make the patient very uncomfortable when you dismiss them and they go home. And we don't want that. We want them to be feeling good and very clean at the end. So
Also, I think the biggest downfall is the taste factor. And we know how taste driven our patients are. They're very vocal about it. If you put something yucky in their mouth, they're like, note that in my chart, never again. They're sensitive about the temperature of the water. If it's too warm, why is the water warm? Um, but that's one of the reasons that we teach that method too, is it gives us some more control over the product. So we typically recommend the gel. That also gives you more control because you are applying it, it's staying where you apply it. So 2 or 3 teeth, go in and suck it off with your suction first, then rinse it. Because if you just go in and rinse that gel, if we think about gel, it's just going to stick to any surface that it comes in contact with. It's going to get on the tongue, the soft tissue, and we want them to have a pleasant experience. It's very similar to the taste of etch, and it's also similar consistency. So when you think about when you're going to apply a sealant and we're doing the etch step first, we always go in and kind of suck it off with this suction before we rinse because it gives us more control over how we're rinsing it, right? So
Mm.
if the patient can, not experience that
That's
taste,
right.
they're going to be okay with you applying it again one day.
And so after at the end of the appointment, when you do it again, how are you preventing kind of like the overexposure, or are there things like a fluoride varnish or whatever that you should apply right afterwards to kind of help kind of calm the hard tissues down or anything like that? Is there anything else that we need to do there?
I don't no, we really don't train on anything because I don't think it's necessary. I think, for instance, let's touch on the possible sensitivity a patient could have. We are removing that smear layer, that's what we call it, that layer of toxin. So I think naturally when the dental tubules can be exposed with possible recession or areas that are cleaned up, we would definitely recommend a fluoride varnish for the patient following a treatment, especially if they're doing like SRP that day. But
Mhm.
I don't, I think after they apply it twice, right, which twice is the recommended amount to apply, right? Once in the beginning, once at the end. But there really isn't any additional post-op that you need to think about with the patient. That's one of the beauties of this product is that they can leave the chair and not have to worry about anything post-op.
Excellent. Excellent. Now, for sorry, get to the minutia, but the coding, the costs, any other things that you think the hygienist is going to need to know about to complete this procedure, whether they're in a DSO or whether they're in private practice, it kind of doesn't really matter. How does that part go?
We right now do not have a desiccation code. We are hoping that eventually there will be one. In the meantime, as your manufacturer, we can't legally tell patients or tell hygienists how to code, so it's really up to them. But what we are hearing is that there is not great reimbursement insurance wise for this right now. So really any code that you see fit for that product, which seems to kind of be the miscellaneous code right now, the D4999. That's what I think most are using. Some are not even using that. They're just keeping it internal within their own organization for tracking purposes. The syringes come in the 1 milliliter is a 2-pack. So I think retail is around $64. And the half milliliter comes in a 10-pack. So it just depends on how you want to order it. And then as far as charging, really, this is up to you guys as well. You can charge per syringe if that makes more sense. You can charge per quadrant. You can do a flat fee and just add it to your service that you're providing. So we see and have heard a range of pricing.
Yeah, I think the most effective one right now is D4999, a miscellaneous code, charging per quadrant, or like Lindsay said, per syringe. It's really up to the office how they want to come together and do that. So I think it's great really for the whole office to get involved in the implementation of this to help like with front office and back office. But D4999 is probably the highest recommended. But again, it can fall into other codes depending on how they're using it.
Pretty low cost, low acquisition cost. So like Lindsay
Osborne.
mentioned, it's $64 retail. That breaks down to $32 a syringe. And if you're applying it for SRP and you break that down even further because one syringe will treat 2 quadrants, that's $16 a quad. So it's definitely something that if we're charging the patients out of pocket for it, we don't feel like we're presenting them with a $500 treatment plan for something. So it is cost effective, it's affordable. And I think as hygienists, we don't get so caught up on the number situation. That's not really, where we see ourselves. We see ourselves, selecting things that are beneficial for our patients for sure. But I can sleep easier at night recommending something for my patients that's not going to cost them, $1 million. So I think that's one of the huge benefits. The cost, $16 a quad. And we have offices that charge, if they do charge by quad, they're covering their cost by charging 2 to 3 times what their cost is, what their acquisition cost is. So if we think about that in terms, that's not a huge cost for the patient up front. That's, maybe $50 a quad versus $500. So
Yeah. It's not taking out a second mortgage on the house kind of a situation, right?
exactly. Like, there
Yeah.
goes my vacation fund. Dang it.
Yeah. Yeah, I love how you explain that because it's true. It just makes it very feasible
Mhm.
for
Yeah.
the treatment plans.
And cost
And
is such a driving factor for our patients. Like, let's be honest. That's one of the reasons they may choose or not to choose to do treatment that we're offering them is the cost factor. So,
And one thing I'll add, kind of tying in the clinical side with the cost, is we hope that PerioDT would be a product that you would only have to apply once a year, or maybe if that, right? Like, let's take your SRP patient, for example. If you do the whole mouth with PerioDT, or you're adding that adjunct in that same day, there is potential that you will never have to place PerioDT again if your patient can keep their oral hygiene up and they come see you regularly for perio maintenance visits. Maybe you'll have to apply it locally, but this is not something that is needed at every appointment to where the patient would have that out-of-pocket expense moving forward. Yes, they may need it in local areas moving forward, but I think it's a great opportunity for patients to have such an superior adjunct offered to them, and then also give them the opportunity to keep it at bay for a long time.
Now, the kind of the last question I had though is, and then I forgot to ask this in our other conversation, but were there any like health contraindications that we need to be thinking about? Is this ever going to not be good for somebody? Like, we use it on, I worked in pediatrics for a while, and we'd see that
Right,
little
I know.
10-year-old that has just a train wreck. Is it safe
Yeah.
for them? Is it okay for, people who have health issues?
So the contraindication is a sulfur allergy, and we don't have studies to prove that it is safe for pregnant patients or those under the age of 18.
So the guidelines there are just 18 and older,
18 and
and
older. Mhm.
opt not to for. Right? You all are going to be at RDH Under One Roof. Do you guys have a
Yeah.
booth number by
Yes.
chance?
Yes.
What
We're
booth number are you going to
excited.
be at?
Oh, we're at booth number 406. Yes.
Nice. And so all three of you will be there. Is that correct?
I guess
two of us going now. Super disappointed,
I
but
know.
I mean,
Monica and I will be
Things
there. We
happen.
are missing our third
Yeah.
amigo.
Yeah.
Peggy won't be there.
I know I'm sad. But my sister will be there. She's a hygienist too. She'll be at the booth. So
Oh,
there are
excellent.
going to be lots of other, yeah.
And
Excellent.
Lindsey and I spend a little bit of time at the booth, but we'll be mostly meeting with a lot of our customers, attending some CEs. So we'll be around and about. Please contact us. We'll be so excited to
Yes,
hear
we'd
from
love
you.
to meet you and chat.
And I'll
And
just be living vicariously through them. So
Oh,
you'll see all the Instagram stories come by and like, oh, this is fun. This is fun. Oh, there's a networking
Yeah,
event, and you're
serious
missing all of
FOMO.
it. It's gonna be the worst. And if someone wanted to check it out on the website, where can they go to find more information?
yes, they can find out more information at youngspecialties.com.
We have a live webinar coming up on July 15th for non-surgical periodontal therapy. So we have a KOL talking about PerioDT. So we can do a shout out to that. And also we have an on-demand portal at our Young Education website that if hygienists want to go in and watch on demand, we have 2 separate courses with Anne Guion where she brings and pulls in case studies on PerioDT. So I think it would be a great educational time for the hygienists. The Young Specialties Instagram page is really, really great. I think they put on a lot of like our new technology on there. So I'd love to give the handle for that. Let me find it though. I don't have it.
Yes, it's at Young Specialties is their handle.
Awesome. All right. Well, thank you so much for being on.
Thank you for having us.
Yes,
It was
thank you so
great.
much.
Thank you for having us.
Thanks.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.